12. It'll be our first shot at some sediment. So, renal epi, transitional, squamous, mucus, hyaline cast, red cell, white cell, bacteria, sperm, and an artifact, like an air bubble, or potentially an air bubble, or
Fiber?
no, I was gonna do like a starch, like from your gloves, that look like, and you're gonna get them commonly, and they kind of reflect back, and they're almost like little mirror-like things. So those will be the potential 10. I'm gonna give you 12 slides, and you get the best 10 out of 12. I'm still finishing the third PowerPoint, but you got 3 sediment PowerPoints. Graph has great pictures. You can Google any of these and just, because that's what I made my last one. I just Googled and saved 3 pictures, put them on my PowerPoint. So you gotta know these 10, and I'm gonna give you out of 12. So that'll give you 2 messes.
Is it Tuesday?
It'll be Tuesday when we do our regular test. Because it shouldn't take long. We're gonna do it right away. Yes.
So if you do them all, do you get bonus?
Maybe. So if you get 12 out of 12, it might be worth a couple bonus points. So that way it's kind of fair. It's our first try at it. And I was pretty impressed how you were doing with what we've seen so far. And I don't think anybody, it's bad to add a sperm. I think all of you should be able to identify a sperm if you saw one. So I don't think that one is too tough to identify on a picture. So I think, and I only had the hyaline cast. Oh no, you know what I need to add as a cute one? Scratch the artifact. What do you think I'm going to add?
Crystal?
Yes, which one?
Calcium.
Yeah. But this time I'm not giving you the pH because you'll know it because it's only one crystal. So calcium oxalate. So that kind of will go over what we've seen. We haven't seen the sperm, but I thought that was an easy one to add. You should be able to identify that. And the hyaline, they are tough because even when you do stain, they don't usually absorb the stain, and you really have to play with your light to be able to see them. What's going to be your flag on the dipstick that you better look on your edges for cast? On your dipstick, what goes with kidney? Protein. You get 100 or more protein, you better be thinking, I'm scanning my edges to make sure I don't miss any casts, and then your other protein substance would be your cells and your bacteria. So correlate. We already saw red cells didn't correlate. Did anybody see hardly any red cells today? No, even if the blood showed them. And why would the blood still be positive? If it breaks down to what? Hemoglobin, you're still going to be positive on your dipstick. Yes.
Okay, so you just answered it. I was like, couldn't you have a high blood, but your
Yep.
protein still be out of the roof?
And we already saw in 24 hours, anybody that had blood hardly had anything. We might have saw on, was it on me or what?
It was the patient.
Yeah. So that's the issue. Blood deteriorates probably the fastest of any cell that we've seen. So now we're going to get into what I tried to do, and I saw on one of my slides I didn't highlight the key thing, but this book, I even flagged this book in the back. It puts the diseases, and then it tells you the key piece. So once we get done going through the diseases, we'll pull this out too. And if you look on Blackboard, I have some of the case studies from here already on it. So there are case studies from this book already on Blackboard. So look under the reading. I've tried to put some stuff out there on Blackboard for you. I thought I had flagged them. It was really good how it'll say like the key thing. So we will look at that too. So we're gonna go over key ones. There's a ton of disorders. We're gonna kind of flag key ones that I think you're gonna see with the registry and see for real. And we're gonna have you, like on that chart, I would keep your study guide chart and try as we go along, flag or bold or circle anything that might be a way to identify that disease because of that key cell. So you should already be able to tell me, what would you see on a true UTI? What would you see on the dipstick, and what would you possibly see on the microscopic?
pH
Higher than 7 pH would be a flag. Like the one that had 9, we didn't see, who had that urine that had the 9 pH and we ended up discarding it? We didn't really see anything, and so I don't know. Usually 9 pHs are invalid urine, so I don't know if that's something, if that urine was older than just yesterday, because I was surprised, you know, it had all that, because we saw nothing on it. It was one of our boring ones. And usually that's like an invalid pH, like something is up with either the collection or,
I have a question.
yes.
So would pH affect the leukocyte coming up on the dipstick, do you think?
I don't know why yours is not showing. It didn't show in the manual either.
My pH is 5, not high, like.
Yeah, but I think my pH is, remember my pH, anybody? I'm sure I'm acidic.
Yours was 6. mine
I'm
was
less than 7 and my leukocytes showed up. So I don't know, because you definitely had plenty that you would have warranted, and they don't look like they're not the typical neutrophils. They look like the granular neutrophils. So I don't know why it's not detecting your esterases in them, because it didn't show up when we did it manually either. It didn't turn purple at all.
Is it possible to have one who aspirates differently?
I mean, I could say if she was chronically sick all the time and she had bacterial infections all of the time, then, I mean, what was your white count in hematology? And when you did your diff on your own blood, did they look typical? Did you see granules in your neutrophils? Because your neutrophils are granulated. I mean, did you see anything hematology-wise that would make you think, oh my gosh, my neutrophils look weird?
Were your white blood cell counts when we drew them red? Weren't they always low?
I can tend to be on the lower end of a white count, sometimes down at 5,000, but
Ours was
I,
like 4.
but I still have the normal percentage of like 70% neutrophils. I mean, where's your CBC 60 to 70% lymphocytes? I don't remember Diane ever telling me someone in the class had, oh my gosh, their CBC is showing. So I don't.
Well, it would be a HIPAA violation. She couldn't tell you. Sorry.
Well, remember, we're the hospital here, and what stays where it is. We're not going out there with it, but we already know there's something wacko going on with me, and this happens every time I teach this, and yet I don't walk around thinking, when I do the urine for my checkup, it's always normal. So we know. I've always had, it seems like, white cells, but now I've got all the other stuff showing up. Okay, so what we're gonna do, we're gonna go through the disease states, then we're gonna do a calculation called a creatinine clearance, or some places it's called the GFR, the glomerular filtration rate. And I don't know if Barb talked at all about an estimated GFR in relation to the creatinine. We're just doing the typical regular glomerular filtration rate. And you're gonna have to do this on the test too, so you're gonna have to know how to use the formula. And I even put a thing in your syllabus that's called a nomogram, and we're gonna put up heights and weights, and you're gonna have to give me the surface area and be able to read the nomogram. So you're gonna need your syllabus when we get to the creatinine clearance test. So there are so many disease states, and we're going to key into the ones I think you'll see and clinically and on the registry. And then on the creatinine clearance, I think all of you will see it in chemistry. That they have to do a 24-hour urine, and they have to get the serum creatinine, the urine creatinine, and you have to, at least St. E's, we had to adjust the surface area. I think Barb has you do it without adjusting the surface area. I don't think you had to do anything with the surface area when she had to do creatinine clearance. But for me, you gotta adjust it. If you're a smaller person or a larger person, it's gonna affect your GFR. How are you clearing waste products? If it's low, that's all we're gonna worry about. That's a problem. Your kidney function is not proper in the glomerulus if your GFR is low. For us, that's what we're gonna worry about. A low GFR in relation to poor kidney function. So that's what we'll end with, is that calculation and a little bit of discussion about osmolarity. I kind of went in the order that Graf did their disease states, but you know me, I like the Strassinger too. So between the 3 books, I'm sure I'll be showing you different stuff between the 3 books, but I think they all have value. But I tried to do the PowerPoint based on Graf, since that was the required book. But I'm also going to turn to the Strassinger if there's something I want to show you from it as well. Okay. So we're going to, if you were going to give me what you would see on a patient with a UTI, a typical cystitis, like a bladder infection or a lower urinary tract, nothing to do with the kidney, what are you going to see on your dipstick?
pH higher than 7.
Possibly pH greater than 7.
Nitrite.
Not always. Nitrite could be plus minus. Why? Gram positives would be the negative. Gram negatives would be the positive, nitrite. And you got to realize that. And we'll learn in micro, gram-negative bacteria convert nitrates in your body to nitrites. Gram-positives don't do that. That's why they're negative on the nitrite. And you might see leukocytes, right? And why might you see protein? Protein are in cells, protein are in bacteria, so it's common to have protein also. Some people, depending on how severe the UTI, they might even have spillage of some blood from a UTI. But these are probably the 2 critical, that then you see bacteria and then you see white cells under the microscope. So keep in mind, because you're going to get case studies, what might be a key finding for each of these disease states. And I saw one, I flagged red cells instead of the red cells cast, so we're going to have to highlight that. Because I saw one that I didn't bold the right thing.
Did you say that was for kidney?
Nope. Lower urinary tract infections like a cystitis. All of us just say what? UTI. And put phones away if they're in your laps. Remember I told you last class, no phones unless we're doing something like taping, or I'll let you use them to calculate today since I didn't tell you to bring a calculator. So a UTI, did you see anything up here that says there's a cast? No. So pay attention on your test when you get a case study. Go through and circle anything that seems abnormal. A regular lower UTI is no cast. Keep that in mind. Okay, we're going to talk about kidney stones. They have a few of the pictures in this other book. We're going to mainly worry about calcium oxalate as a component of a kidney stone, but they did show some pictures of some of the other stuff they say that can be in a kidney stone. They call that urolithiasis. That all that is a formation of a kidney stone. That's just another term for it. And calcium oxalate is one. Sometimes people drink a lot of milk products. Sometimes we're going to know that as a main 264. Let me see if it shows the other ones. But kidney stones will be another thing we go into that can, they call them oxalate stones. But there'll be other things listed. Vascular disease we're going to go through. Anytime you affect the blood supply into the kidney, you're going to cause problems. If you have any deterioration of blood supply, that's the only blood supply you have. It's not going to reroute from somewhere else to get to the kidneys. You mess up your vessels to the kidney, you're going to have problems. Diabetes mellitus with diabetic nephropathy. You have problems that can be with an untreated one. Glomerular disorders we're going to go on to. We're going to talk about acute glomerulonephritis and chronic glomerulonephritis. Then tubular disorders, the interstitial the tissue surrounding the tubules, and then renal failure. A lot of things can lead to renal failure. And what kind of output you think you're going to have if you have renal failure? So it's going to be anuria, right? You know you're starting to have problems if you get to oliguria that doesn't improve, that you don't ever go back to normal output in a 24-hour period. So basically anything below 500 mils per day is signifying something's up, okay? So these are some of the examples, and what you'll have to know for your test are the ones on your study guide. But if you look at either book, you're going to have more than what's on that study guide, okay? So the UTI, oh sorry. See the right thing? Kind of like my glasses, huh? So it's not a nephron. Leukocyturia is the same as extra white cells, extra bacteria. Hematuria could be blood. Proteinuria, there are no white cell casts. Because typically I'll do a comparison case study and people get it wrong, and it's pyelonephritis versus a cystitis, and it's all dependent on those white cell casts. So, and the CAP book even flags that. So I try to flag key things that if you don't even know anything else, if you remember that key thing, you'll get it right. So a regular cystitis has no white cell cast. Remember that for your registry and for my test. Okay? That's lower urinary tract. It doesn't involve the kidney. The kidney stones, has anybody ever had one? A lot of times there's typically someone who's had one. Linda, now they can do, my daughter-in-law had one, and it was very painful, but she had to go and they actually do like an ultrasound vibrate thing, and she was so sore, which shocked me that she would be so sore for like 3 days, but it ended up breaking them up, and she then voided them on her own. They didn't have to do any surgical procedure, and the only thing they attributed to, she was drinking those protein shakes daily, and sometimes more than once a day, and they don't know if she had never had problems ever before, and it was before their wedding, and trying to lose weight, not eating anything, and probably not drinking as much water as she should have, and it was bad. And so hers were calcium oxalate. There are some other stones they talk that can be calcium phosphate, magnesium ammonium phosphate, uric acid. We'll talk about amino acid problem with cysteine when we get to the amino acidurias. That's a pathological crystal that has a hexagon shape that they can kind of clump together and form a stone. Probably the most typical one for now that you could be familiar with would be calcium oxalate. So sometimes people will have the kidney stone that you can expect that you might have crystals in your urine, plus you might have protein. Plus you might have some blood. You know, especially if you're having trouble voiding them, they could actually be fresh blood. Now, with vascular disease, the key thing, there's high blood pressure that ends up leading to possible damage to your blood vessels. The ones going into the kidney, the renal artery, and then the rest of the blood supply. And have you learned with Barb already the BUN and creatinine? Which one's the better indicator that's not affected by what you eat and drink of the two? Which one's stable? If you had to pick one kidney test to do for me, I would pick one of the two of them. The creatinine. It is very stable. It's not affected by how much you drink, your diet, your activity. So that's a great way on the chemistry end to see if you have problems with your kidneys, if your BUN and creatinine are elevating. So as we get to our worst disease states, you're going to get higher levels of BUN and creatinine. When we would do dialysis patients, we knew they were ready for their dialysis. Their BUN might be, I don't know, might be up to 90, and their creatinines would be like over 5, which is drastic to have them that high. What's creatinine? Up to like 1.1, and BUN is usually like 8 to 20 mils per minute. So this, and anybody remember where we saw this in COAC? What two disease states had platelet clumps that had to do with a high BUN and creatinine?
Was it
HUS, hemolytic uremic syndrome, and it was another one.
I can't think
DTP,
viral one?
thrombotic thrombocytopenia purpura. And didn't you have a leukemia that had DIC as one of its classic characteristics? It used to be called M3 back in the day, I think when I taught it. Prothrombin, maybe, not prothrombin, but your myelocyte, it was more the myelocytic one, was M3, and it had DIC as a classic feature. I don't know in your new classification what it's called now, the WHO. Do you remember what it is, FAB versus that? So those are little things where you start putting things from every class together, and that would be a thing to know for your registry, the one that has DIC associated with it. Okay, so this is what we mean by putting it together, and that was, we had my advisory meeting yesterday, and that was the biggest complaint, that our students aren't getting the whole picture. They're like robots. They can come and they can do the COBUS. They can come here, they can do the CA240. But if you had if they had to do hematology, chemistry, go back and do a UA, they can't, oh my gosh, I can't go from thing to thing to thing, department to department. So on both ends, we're going to try to improve that. We're going to think about doing something at the end of the 2 years where you have to do multiple different procedures from different classes. And then on their end, we said, okay, what about this? If you're in heme, coag, UA, serology, and you have one student, we have 14 or 12 to teach. How about you do an overall practical where when you're done at your clinical, that last week, they make you do all the machines. Not just ones in chemistry or heme, but you have to go, okay, I have to go take the specimen in all the departments I've learned and draw the blood. So they were saying that our students sometimes are too robotic, that they can do this one thing, but don't you put them elsewhere and let them think. So we have to try to work on improving the critical thinking. So that's what we're talking about. You know, where'd you learn that in chemistry? Then you tied it into urines. Then remember in COAC. Okay? And that's complaints from the clinicals. I had 10 of the 13 sites there yesterday. It was incredible. It was just awesome. And you get good interaction, and we have found that some people who go to the smaller facilities do better because they don't have as much volume, so the students have to go everywhere right away. One of my students went to Sparta and then had to do some extra blood bank at Anderson, and she said, I was bored at Sparta. I went around and did coag, heme, UA all in one day. And then they're, okay, I gotta wait till a blood bank specimen comes in and then I don't do anything else. So I learned from listening to her, she developed more critically her critical thinking by being at the smaller facility because they made her go everywhere. So those of you who are saying, oh, I didn't get to go to the big place, don't minimize the small place. It sometimes gets you to be more independent worker. So one of the things with vascular disease, the glomerular filtration rate will be a help. When we teach you, we're going to do the real, we're not doing an estimated one, but we will take creatinine levels from serum, creatinine levels from urine, and we're going to see how many mils per minute does a person void. And if it's not in the normal range, if it's below normal, you know they're not filtering properly out of their glomerulus. And so they might be having problems with waste products building up. Diabetes mellitus, you already know you exceed the renal threshold. The insulin can't handle what you have excessively in your bloodstream. And it's, even though it's a large molecule, it's still forced out into your urine. You might see in the process, some of the small blood vessels are injured. And a person going into diabetic nephropathy might end up having damage permanently. And I think you're going to be more at risk if you're a type 1 where you've been insulin dependent for a long time, and if you have your hemoglobin A1C high where they don't keep it in control. And I've told you about my nephew, he's a perfect case in point. Eye problems already, kidney problems already, and he's 40. So I would say type 1. You know, have we done your dad's urine this week? I would bring it in next week for sure. You know, because we haven't taken a look at it under the microscope, I don't think, just to even see.
I meant to bring it today, but I forgot.
So take a cup with you before you leave and just tomorrow and just bring it on Monday.
Okay.
We already know sometimes they even have problems with the retention of water and salt if the kidneys aren't functioning properly. They might have some nerve damage where they might not be able to empty their bladder because of the nerve damage. They might also be at risk for UTIs because they get sugar in their urine and any bacteria may multiply. Typically though, someone with uncontrolled diabetes or spilling of it, you shouldn't see anything under the microscope. There's no guarantee every person's going to have bacteria just because they're diabetic. And if it is, it's probably going to be more from the skin, not necessarily in the urinary tract. So what would be your key findings? So if this is the dipstick, like in the case of your dad, what was the key finding only?
Specific gravity and glucose.
What was his specific gravity? I don't remember.
It was
Is
10
it
one.
20s?
It was 10 one night and 20 the next time.
So I would typically think it'd be over 20, but you're going to have a higher specific gravity, and I would think at least 20. But in your case, he had only glucose positive. I don't think we ever got the ketones,
No.
that he was spilling ketones.
Nope.
But most people, if you have 1,000 blood sugar, you're going to be breaking down fats incompletely because you don't have enough blood sugar into your bloodstream as your energy source, that you're going to end up breaking down something, and that's when ketones. So at least you would think on a diabetic with 1,000 milligrams of glucose that you're going to see ketones too. But minimally, you'll have a high specific gravity in glucose. Unless there's bacteria present because you didn't do a clean catch, you shouldn't see anything under the microscope on a diabetic. So unless there's bacteria, if it's not a clean catch and there might be glucose that it's feeding off of and you didn't do it within the hour, typically that's what you're going to see on a diabetic. You're not going to see anything under the microscope. So keep that in mind. This is, yes,
I'm feeling really sick. Can I go?
I was wondering. You didn't look like, now you guys have been taping them, right? And putting them
Yeah.
up? So just, are you like nauseous sick or?
Yeah, like acid reflux.
I mean, are you okay about driving?
Yeah,
Anything?
yeah, I'll be fine.
Acute glomerulonephritis is the first, this and pyelonephritis I can almost guarantee you're gonna see, not only for me, but on a registry. this, and commonly, one of the most common causes is when you have an antigen antibody, which you'll understand better once you get in serology. Typically, if I have strep throat, some people develop an antibody. So you get infected with the antigen, which is the strep. Your body makes a response and produces an anti-strep antibody. Well, if your system doesn't clear, they call it immune complex. Antigens and antibodies fit like a lock and key. They have to match up. If you don't clear them properly with your reticuloendothelial system, if they don't, they stay hanging around. People who have had a recent strep infection can deposit the immune complexes, these antigen antibody pairs can complex on your glomerulus and cause damage. But in that case, usually it's self-limiting, that you initially might have things being filtered in the urine that shouldn't be, and you might have protein being spilled, you might have any analyte being spilled, even if it's heavy or a small. But it's self-limiting. Once you get rid of these immune complexes, the glomerulus heals and it's back to normal. So that's the good thing. So you would think acute would be worse than chronic, but in this case, chronic glomerulonephritis is worse. And that's opposite of what you usually think. Acute, and I should have flagged, so circle red cell cast. I shouldn't have flagged red cells. The key finding is red cell cast. So that's probably the most common scenario. There's one they call it when IgG complex is out, called Berger's. There's non-immune when you have maybe antifreeze. You drink, someone trying to get rid of their husband or wife and have them drink antifreeze. It could damage the glomerulus and trigger acute glomerulonephritis. But a common one is after a strep infection. You're going to see, on the dipstick, you're going to see the blood, you're going to see the protein, you're going to see specific gravity can be higher due to the cells, and you're going to see red cells, usually fresh, if it's a fresh urine. Anytime a urine sets, you're going to lose it, it's going to become hemoglobin. Still be detected on the dipstick, but it'll be hemoglobin. But what happens is you get these red cells to be trapped by a hyaline cast, and you have red cell cast. Many times they just look like brownish hemoglobin cast as they develop into the tubules, but this is the big finding. You might have, anytime you might have a granular cast, think about it this way. You have hyaline, then if hyaline trap any cell, you have a cellular cast. If the casts stay in your tubules too long, they break down into granular cast, and if the granular casts stay in your tubules too long with anuria or oliguria, then they become waxy and broad. So anytime you have a cellular cast, depending on how long it stays in your tubules before it gets voided, it can become a granular cast. I don't care if you can distinguish for me coarse or fine, as long as you know it's a granular cast.
When it's broken down into the granular cast, it's still going to have that very cylindrical shape. It's never going to be like bent.
Granulars are still usually rounded ends. It's when they become waxy or broad that they get more rectangular with the notches in them.
Yeah, but the I get the rounded ends part.
Mm-hmm.
I found one, it looked like a granular cast, but it was bent almost into like a slight U shape.
Well, things can get bent. You even saw how some of the squamous looked like they laid on their side and were weird shaped. So I'm not saying a cast won't ever get bent, but it's usually not as big as a waxy or broad, and it's not as square and rectangular like. And as you're new, don't call casts that aren't rounded ends. And if you ever think you see, especially anything other than a hyaline, you need to show us. Whether I have Barb helping me or it's myself, or even when you're at a clinical. Don't go calling something, just like if you're doing your diffs. and you see something that's gonna be, you're gonna call a leukemic cell, like a blast, you better let someone look at it before you go calling it. Don't think I gotta know this, I'm gonna be smart and show them, especially if you don't have any previous results. It's better to be correct for the patient's sake than to say, hey, I'm gonna show you how good I am. I told you about my case at Centralia. The student was following someone and did diffs and saw myelocytes and metamyelocytes, and they hadn't been reported. And she just was asking because she goes, I want to just make sure I'm calling him right. And they were right, and that tech was furious. She thought she was trying to show her up, and I couldn't even send her back there the next time. And she goes, Jean, I just wanted to make sure I was calling them correctly. So it's all how you handle yourself. So don't ever think as a student, they expect you to ask for confirmation on anything very pathological like a blast. And anything, before I'd call a waxy or broad, I would want to make sure they had symptoms. You know, was it high concentrated, was it low output, especially if you're gonna call more than a rare one. Have someone else take a look to make sure. You saw some of you had fibers and stuff in there, that it's just not junk. So the key thing is gonna be your red cell cast with acute glomerulonephritis. And I'd say a very common case study you'll see even on the registry is in association with someone having a recent strep infection. Very, very common to be associated with immune complexes after that infection damaging the glomerulus. Do you remember in COAG, which one followed viral infections possibly in relation to platelets?
Is that the kid one?
What was the name of it?
No. I just know it was in kids, wasn't it?
Acute ITP, idiopathic thrombocytopenia, and there was chronic ITP. Acute was the one with children, commonly after it was idiopathic, so they couldn't say for sure, but it was commonly after kids who had viral infections. You know, I think one of the examples I used was chickenpox a child had, and then all of a sudden their platelet bottomed out to like 20,000. Chronic tended to be more women and not as low a platelet count. And which one was harder to treat? Which one was self-limiting? The acute was usually self-limiting, didn't need treatment unless they fell so low. Chronic glomerulonephritis, it is glomerular damage that won't get better. And it doesn't have to follow acute glomerulonephritis. It can follow any kind of disease state that the glomerulus is not going to recover. And many times it can lead to end-stage renal disease where you have anuria and you're not voiding anything. So remember, chronic is worse for the patient than acute. And in a typical acute case is self-limiting, especially if it follows a strep infection. Naturally, if you've ingested something poisonous or a toxin, depends if that damage is irreversible, how much you're on. My neighbor lost her kidney function and has a kidney transplant, and to this day, she does not know whatever triggered it. I feel she has to have been exposed to something, either in the environment, either some medication she was taking, because she went from being healthy, perfect kidneys to getting sick like she had the flu when she was doing the accounting for one of the businesses she did it for, to going, couldn't do any of the dialysis, had a blood clot here, couldn't do the stomach one, had to go to a transplant, and they never figured out what triggered it. Healthy, this happened like 10 years ago, and I bet it was something chemical. Another lady, some drug she was taking went into leukemia, and it was the M4, I think M4 is the myelomonocytic, or M5 is the monocytic of when you do the FAB classification, and it was from a medication she was on for some other disorder, and it triggered her to go into a leukemia. So sometimes you're gonna have stuff you take that you don't know if it's gonna cause damage In her case, the bone marrow. In the case of my neighbor, it was damage to her kidney that was irreversible. So sometimes the toxins and something you ingest or are exposed to, you know, you might get it, the next person could handle it and not anything happen. The key thing with chronic, no matter what it's caused for, you're going to have the blood and the protein. You're usually going to have swelling starting and oliguria, and then if it continues to anuria. But the biggest thing, especially if the glomerulus is damaged where it's not reversible, you're going to even have big molecules spilling over, like the glucose, which was different from acute. We didn't have glucose. The big thing is you're going to get to the waxy broadcast. So in chronic, you're going to definitely have waxy and broadcast. So you're going to have to pay attention to output. If you suspect chronic, you're going to at least have oliguria leading to anuria. So they're not going to void over 500 mils in a day. That should give you a little clue they're not voiding enough. They have something definitely going on with their kidneys that isn't self-limiting, that won't reverse itself. And would you expect the BUN and creatinine to be very high? Yes. When you get to chronic, you're going to have a very high BUN and creatinine. If you start getting to the point where you're going to end your renal function, your BUN and creatinine are shooting up because you don't have any way to clear them unless you're on dialysis. So like I said, when we had people who, back in the day when they only did the blood dialysis, they did it every other day for like 4 hours on those 3 days, you could tell because they also tried, you'll learn with blood bank, they usually tried to keep their blood low. Most of them only had a hemoglobin of like 8. Because they're dialyzing and clearing that blood, they really didn't care for them to be very high blood count. So if they fell below 8 NASH, they're going to give them packed red cells. But we also knew they were ready for dialysis because their BUN was sky high and their creatinine was sky high. So think, acute is better than chronic, and acute can be self-limiting, especially in the case of strep. Chronic is not going away. Many times chronic is going to end up going into renal failure. So chronic is the bad one. Chronic can come from many types of disorders. It isn't just from one cause. And your biggest features are going to be the high BUN, the waxy, high creatinine, the waxy, and broadcast. The waxy and broadcast should tell you not voiding well. You see waxy and broadcast, any good amount, they're not voiding. They're staying in their tubules long term. So chronic is the worst. And a lot of times the filtration rate, if probably a general normal, we have to know normals for male, female. General normal, let's say nothing lower than 80 mils per minute, what is filtered. You start getting less than 50, and end stage you get less than 25 mils per minute. So they call that the GFR is very decreased. And we're going to do the calculation. Creatinine clearance, GFR is one and the same. Creatinine clearance just is the substance we're measuring is clear. End stage, you're going to probably be closer to less than 25 when you're almost to the anuria. But if 80 is normal, you're not going to have a normal GFR. So keep that in mind. And if you hear the term creatinine clearance, it's the same thing as GFR. We're going to go through why they choose creatinine to see if it's cleared. It's not a perfect substance either, but they try to measure something that is part of you. All of us have creatinine. It's called endogenous. And the only problem with creatinine is if you had a muscle wasting disease, because it's in all muscles. Like if you had muscular dystrophy, you would probably not have a valid creatinine clearance. But there's no perfect substance to use to see if your glomerulus is filtering properly. But if it's too low, it's not. So you're gonna have waste products build up. If you had a medication and you were worried about it building up and getting too high, did you guys talk about therapeutic drugs yet with Barb? Like TDMs at all, gentamicin, tobramycin, all the Dilantin for, she'll teach you have to do a trough value and a peak. A trough is when it shouldn't be high at all. If some people have a low GFR and it's like a half hour before you're due to get your medicine, that trough level better be low. If it's high, what's that telling you? Your kidney is not clearing it. So I'd say if you did their GFR, I bet they have a low glomerular filtration rate. They better watch how much medicine they give them, because then you do what is called a therapeutic or peak level of that drug. And if it's toxic, if it's too high, so you got to pay attention if your kidneys are clearing it well before you give them their next dose. So you're going to learn therapeutic drug monitoring with Barb too. And that is a big deal. Even blood drawing, anybody had to do, I know you probably have to worry about peak and trough drugs. You want to draw them when it says, because if it's supposed to be a trough a half hour before their dose, and you go, oh, I'll go, half hour later, who cares? And they gave them the injection already, you're not going to get a valid value. So this GFR is a big deal if a patient isn't clearing their medicines properly and they're building up. So in chemistry, that could affect certain drugs. Before you give them the next injection, you better make sure their trough one is good. So the GFR will be a key thing, that I think all of you will do in chemistry. Nephrotic syndrome, once again, just like chronic, there's many things that can lead to, especially the basement membrane of your glomerulus being damaged. This one is something you're going to see a lot of places. I've only had a couple real cases at St. E's, because you know how we talked about renal epithelial cells are bad. They're from the kidney. Well, there are these things with nephrotic syndrome when you have damage to the basement membrane that it ends up triggering a lot of things. It'll cause massive protein loss. You'll end up, if you lose protein in your urine, what do you think your blood albumin is going to be? High or low or normal? If you're spilling it out your urine and not reabsorbing, are you going to have enough in your blood? No. What is your value? 6 to 8 for total protein? Not going to be, and then albumin is what, 3 to 6? Have you done protein yet with Barb? Okay, so if you're spilling 3 to 4 plus in your urine, what do you think the albumin and total protein are going to be in your chemistry panel? They're going to be low. Okay, so then high serum lipids, and then you also have swelling, you have systemic shock, you have other glomerular diseases are problems. So the low albumin stimulates increased lipid production by the liver. So what happens, you got all these fats being produced by the liver when you have nephrotic syndrome, and you get your oval fat bodies. And what they are, you got these, because of the low serum albumin, your liver is producing more lipids, and the renal epis trap the fat. And they are called oval fat bodies. And they almost look like blobs. I don't know if any of you guys know what a lava lamp is. Back in the 70s, that was kind of something that a lot of people had. To me, they look like circular with little blobs, little brown blobs, but they look weird. So it's not like you can see an eccentric nucleus. You'll see these weird cells about the size of a renal epi, and the way you tell them is there are certain stains. We would have to say, hey, we think we have oval fat bodies in this urine, and we take them down to histo and say, hey, can you stain them with the oil red stain they'd have, or you could use a Sudan stain. Usually oil red was the stain, and everyone that was in oval fat bodies would be bright orange red. And you knew you had a renal epi that had trapped the fat. So what are you gonna see on the chemistry panel that'll help you? High lipid profile, okay, like your triglycerides, your LDL, your, I don't know what else everybody does specifically on their lipid profile. I don't. And you're gonna see what with your protein? Low serum albumin, low total protein. So that your chemistry panel helps. And then what are you gonna have spilling into your urine? You're gonna have the high protein. You're gonna have oval fat bodies. And guess what? They can get trapped in a hyaline cast, and they're called a fatty cast. So nephrotic syndrome, the two key pieces are the fatty cast and the oval fat bodies. So when we go through slides and show you them, usually we show you some that have the oil red stain. And another thing, some of you are going to get to do what is called a polarizer. And it, on anything with fat, they call them Maltese crosses. So you'll have your little cell, and then it almost looks like four white things together. They call it a Maltese cross. So you'll see this polarized light, and it'll reflect everywhere there's a trapped renal epi that has the fat with it, the oval fat body. You'll see these Maltese crosses. And if they're single ones, you'll show them, or if it's trapped in a cast, you'll see them. And they'll call them Maltese crosses. So there are lots of little clues for nephrotic syndrome.
Does this have lasting effects? 'Cause
Yes.
My boyfriend had it when he was younger. He got it by getting internal poison ivy.
And he recovered?
Mm-hmm.
'Cause usually, this is
He-
one of the
he-
bad ones that goes to chronic
He was in the
glomerulonephritis and end-stage renal.
He said he was in the hospital for at least a year, getting like medicine and getting checked out, and they thought he was gonna have a kidney transplant, but
His would be a great one to see results from if his parents had any of it.
yeah, I don't know because it was so long ago.
It just looks like a button.
No, you'll see it when we do more slides.
Oh, you didn't finish drawing it?
No, I have them, they're already on urine sediment, the 1 and 2, but this isn't even as good as you'll see. We'll end with some slides, and then you'll see, let me go to, they're neat. Yeah, you already have 2 sediment PowerPoints on Blackboard that you can see it, and you also, I'm working on the 3rd one.
You said that the Maltese crosses are showing what in the fat
They're just interesting. They're like, these are oval fat bodies. I don't know if you can turn the light off a minute. This is a kind of a good thing what it'll do. This is like an oval fat body, and you see all the little dots. That's what it kind of does. When you have a polarized light, they look like these little dots. They call them Maltese crosses. Because this is not really a true picture. That's just a drawing of it, of polarizing. And this is like an oval fat body that's used a polarizer, and there's little clumps of them. I don't know if they have a fatty cast in here. But yeah, I'll show you them when we're done, because they're very distinct. And the thing you will see though is a lot of them will show red stained, and that's the oil red stain. So a lot of times you're in conjunction with your histology department, because we didn't keep stains like that back in the regular lab. We had to take it down to pathology, and they did the stain on it, and then we could see the oil red. It uptakes the red color. Just keep in mind, and then bear with me, we'll show you. So oval fat bodies, fatty cast, high lipids, low protein, low total protein. Those are key findings, okay? These are just some other ones they flagged. Rapidly progressive glomerulonephritis. I would flag this one as sometimes the kidney damage that results in lupus. You're going to talk about lupus with Diane in serology, and one of the ways a person with lupus can die is if it ends up causing permanent damage to the glomerulus. Okay? So the rapidly progressive, when I'm going to show you the autoimmune slides under our fluorescent microscope while she's teaching that lecture and we don't really have a lot to do in lab, but Christian gives me their ANA slides, and I still, I used to be the person who did all the ANAs. I'll be able to show you the different patterns that go with lupus, and then we even have this neat test called the double-stranded DNA test. They take a parasite, and if you have lupus, this parasite, they have this thing called a kinetoplast that fluoresces. So you'll see in serology how you can determine lupus, and if they have kidney problems, you have lupus that is very bad and goes to the kidney, this is what it's severe damage to the glomerulus that doesn't improve. Okay, so once again, you're going to have chronic with the waxy and broad leading to the renal failure where you have anuria, no GFR, no filtration rate. That is the one with lupus. The one we said that was self-limiting is after a strep infection. Okay? There's another one Diane will talk about called good pastures. It can be a bad one too, where it's a different antibody than lupus, and it can attack the basement membrane. And you'll learn also about complement in serology. If you know anything about complement lyses cell walls. So it can be triggered in your immune system to help you attack cell walls of microorganisms. Well, if complement gets triggered without trying to attack something, it can damage your body. And in good pastures, so something you have to know for Diane is with lupus, you can have skin problems where you're very sun sensitive and joint pain and inflammation and kidney problems. Or you could have good pastures that you have an autoantibody. And what do we mean by an autoantibody? What would you think you mean if you have an autoimmune or an autoantibody?
Texture.
It attacks yourself. And so they're hard to treat because you can't just kill them. You'll be killing something good in your body that your body chose to attack. So you're going to have to learn, especially for Diane, that lupus can have kidney problems. And there's also a good pastures that would have kidney problems alone. Lupus can have joint pain and inflammation and kidney problems, whereas good pastures is kidney alone. Okay? That's about the extent that I'll have you know either of those. The one I think you're going to commonly see is acute glomerulonephritis after a strep infection. That's usually self-limiting. But this should come up again in your immunology class when you get to autoimmune. Another one that damages the glomerulus, they call it Berger's disease. And at least if you know for me, you know that IgA is one of your 5 antibodies. Do you know IgG? A, M, E, D, because you're going to have to know that for Diane. A is in all your secretions. So all of us should have A anywhere we have mucosal secretions. Well, there's a disease where IgA antibody deposits on the glomerulus. So the one thing we've seen as a common theme with damage to the glomerulus, there's been either an antibody or an autoantibody or an immune complex. All of that is antigen antibody related. If you're the poor person that tends to get autoimmune or have problems with antigen antibodies, you might tend to get some of these. women tend to get a lot of autoimmune disorders between the ages of 20 and 50. So some of the glomerulus problems we've seen as a common theme. They've all involved an antibody itself, an autoantibody like in the one with lupus, or with good pastures, or they've been related to IgA, which is one of your 5 antibodies. Something complexes on the glomerulus and causes the damage where it filters too much. So it makes sense that you might have protein spilling more than normal. So this, you don't have to know anything about the urinalysis. I just want you to be aware of what it's associated with. So rapidly progressive, associated with lupus. Do you know that term SLE? Systemic lupus erythematosus. So you'll see this again with Diane. Some people just call it SLE, but it doesn't help you to write it if you don't know what it stands for. So systemic lupus erythematosus is the real true name. I'm fine if you just put lupus. Okay? Good pastures is a different autoantibody that attacks the kidney. So one thing with rapidly progressive, are you only going to have kidney problems? No. A lupus person has joint pain and inflammation. So I would write that. Good pastures, only kidney problems. IgA nephropathy, it's just commonly following some, like a sinusitis would be an example of a mucosal infection. So it's different from the one following strep. Okay, so at least know Buerger's is a mucosal, following a mucosal infection, and IgA is the culprit. This is another big one. You gotta know cystitis, you gotta know acute glomerulonephritis, you gotta know pyelonephritis for case studies. You have to. You're all gonna see those in your career, not just on the registry. What do you think if a cystitis is the lower urinary, then pyelonephritis is the actual kidney infection? Okay, so you're going to have your blood, probably your protein, probably leukocytes. You might have nitrite if it's gram-negative. If it's gram-positive, nitrite will be normal. You're going to have white cells, but the big thing you're going to have that's only with a pyelonephritis and not a cystitis are white cell cast. And remember, you possibly could have granular cast, right? Because any cellular cast, if it's not voided, deteriorates into a granular cast. But this is the hallmark feature, our white cell cast in pyelonephritis. So this is the actual kidney infection. A cystitis is a bladder infection. If they talk about UTIs, they're talking about lower urogenitary tract infections. Pyelonephritis, it is the kidney that is infected. And that is the hallmark thing under the sediment is the white blood cell cast. What's the hallmark thing on acute glomerulonephritis? The red cell cast. What is the hallmark cast with chronic glomerulonephritis, no matter what it comes from? Waxy and broad. The chronic is the worst. You're becoming oliguria to anuria. The casts keep getting larger and larger because they're not being voided. And the nephrotic syndrome, we'll show you some before we get done and move to the testing, because think of a lot of fats being produced in the blood when you have nephrotic syndrome due to the low serum albumin, and they deposit on renal epis, and when you don't have a good voiding, you're going to have the renal epis become a cast, and it's called a fatty cast when it traps them. So far, those 4 are definite case studies: cystitis, acute glomerulonephritis, chronic nephritis, pyelonephritis. cystitis, acute, chronic, and ILO, and then nephrotic syndrome. So we're up to 5 case studies so far. Okay? Where you'll actually get a case with a patient, and then you have to determine it. Acute interstitial nephritis. And this is something I did regularly even when I was just working every 3rd weekend. I almost typically once a month had an order for a urine for eosinophils with the Hansel stain. Okay? Interstitial nephritis. So it's the tissues surrounding the renal tubules. Usually it's associated with some allergic reaction to a medication, which makes sense in hematology then, right? That you'd worry about having eosinophils in your urine. So we had to do a special stain called the Hansel stain. So you're going to have problems with blood and protein in the urine. You might have red cell and white cell cast, but the biggest thing you should know is a clue that you've had an allergic reaction to the medicine is when they order the urine eos, and a lot of times they just say a urine for eosinophils. You in the lab have to know you use a Hansel stain. They're not going to say with a Hansel stain. They're assuming you know what stain to use on urine. But the key finding in this, so we know there's a possible allergic reaction to medication, they're going to order, we called it a urine for eos. That's what they'll order, and that should have a clue that they've had some kind of allergic reaction. And the biggest thing they're worried about is eosinophils that are related to allergies being present in your urine. So many times what is affected is the area surrounding the tubules. So we've seen pretty common themes on all these kidney disease. What we've seen: blood in almost every one, protein in almost every one. We've seen some sort of cast in almost every one except cystitis. But you got to look for something that sets it apart. There's so much information, you just got to find a key finding that'll help you know it's that specific thing. So the key finding is they're looking for eosinophils in the urine when they suspect an allergic reaction to the medicine. Okay? And they call that acute interstitial nephritis. So more the tissues surrounding the tubules. Now, acute tubular necrosis, usually the tubules are damaged. Many times it's due to something toxic. This would be another good case of antifreeze that we saw can damage the glomerulus. Toxins as well as the tubules can lead to ethylene glycol is your antifreeze. But when the tubules are damaged, one of the things, where are your renal epis coming from? From the tubules, right? That is the key finding. In acute tubular necrosis, your key finding are going to be renal epis and renal epicast, which makes sense. Where do the renal epis show up? From the renal tubules, okay? And a toxin is the biggest reason you're going to have acute tubular necrosis, and a good example is the antifreeze. And once again, it's going to lead to kidney failure. So you know what's a common theme with kidney failure? What on the chemistry end? What test for kidney on the chemistry? BUN and creatinine. And then what are you going to see cast-wise, possibly with renal failure? Waxy and broad. But this is what sets it apart. You're going to have the renal epis and the renal epicast. Now this is something I thought was, we'll understand more when we get to the test methods. But there's gonna be, and we'll do it more when we get to osmolality. How do you know nephrogenic insipidus versus neurogenic insipidus? So when we get to osmolality, we'll be able to answer this. But nephrogenic, your kidney can't respond to ADH. So you tell me, what do you know about ADH? What does it do?
Water.
Reabsorbs water. So if your kidneys, ADH, attacks them to reabsorb water and it can't respond, where's all that water going? Into the urine, and you have polyuria and you have a very low specific gravity. Well, we'll show also when we get to osmolality on the test methods how you can say this one doesn't respond to ADH, the kidney. So keep that in mind. Okay?
It does or does not?
It doesn't. So keep that in mind. So you're going to have a low specific gravity and you're going to have polyuria. Okay? And then when we get to osmolality, I'll show you how to differentiate them because they have a really good chart in the book. So diabetes insipidus, as we see, can be to two different reasons why the ADH isn't reabsorbing the water. Okay? So what's the key thing we always have already asked you on diabetes insipidus for you just doing a urine dipstick and micro? What are you just going to see on the dipstick? Low specific gravity. And is anything else going to show? No. Are you going to see anything under the microscope? No. Okay, so the difference with mellitus, you're going to see the glucose, at least maybe ketones, but a high specific gravity. Okay? And then renal failure, and many things can lead to renal failure. A lot of different diseases can, but you're going to have the waxy, the broad. You're going to go from oliguria to anuria. You're going to have a very high creatinine, very high BUN, because it's all staying in your bloodstream. It's not getting ever voided. And your GFR will be less than 25. And remember the isostatenuria? What is your glomerulus? What is the specific gravity when it leaves the glomerulus? 10, and it never changes. So they call that isostatenuria when it never changes from 10. That sends up a flag. That patient's in intensive care and it's always 10. There's something going on there. So these are big clues that you are going into renal failure. Okay? You're going to be, naturally going into no avoiding it all. And it can occur in any area of the nephron. Typically, the worst one, if it's from the glomerulus, it's going to be chronic glomerulonephritis that leads into it. But many different disease states can lead to end-stage renal failure. And like the case of my neighbor, I bet it has to be something she was exposed to. Medication, something, toxin, something. Because to go from perfectly normal, healthy, and all of a sudden it was nothing. And the only thing I wanted to throw in the hepatitis and what do you know? Tell me everything you know that would be a clue for hepatitis so far. What do you know on the dipstick? Color? At least amber, dark yellow on a fresh urine. What do you know else on the dipstick?
Increased protein.
You might have protein, depending on if there's any crystals in there. What?
Trace or more Billy?
Bilirubin and urobilinogen, when it's hepatitis, can both be elevated. And two crystals you're going to learn about for sure are leucine and tyrosine crystals. sometimes bilirubin crystals, sometimes cholesterol, but the two I'd highlight are leucine and tyrosine. And the other day, you gave me different liver blood tests, from Billy to gamma GT to ALT, AST, ammonia. So you also would see liver enzymes elevated if you're going to worry about hepatitis. And a lot of labs do a hepatitis panel, and in serology, you're going to learn about hepatitis A, B, C in conjunction with this. But at least so far, you at least know that much from the dipstick with the bilirubin, the urobilinogen, the dark yellow. And then I put the table of renal diseases in your PowerPoint and the cast associated with the renal diseases in the PowerPoint. So this is an extra little thing that helps narrow what cast is the biggest one associated with it. So let's stop a minute and look at some slides. I think I'll, let me go to one of the urine sediment 1 and 2. Yeah, if anybody needs to run to the bathroom or whatever. Let's go here. And let's just look through a couple of the slides, and we'll do that and show you what we mean by some of the different things we'll see. So you know potential case studies: cystitis, acute glomerulonephritis, chronic glomerulonephritis, nephrotic syndrome, diabetes mellitus, diabetes insipidus, hepatitis, I don't know, some of them I'll just ask for key findings in them, like your acute tubular, we did say nephrotic syndrome, acute tubular necrosis and acute interstitial nephritis. Some of them that are on there, I'll just ask questions, but it won't be in a case study format, okay? So you know for sure, cystitis, pyelonephritis, acute glomerulonephritis, chronic glomerulonephritis, renal failure, and nephrotic syndrome. You know those 6 for sure will be actual case studies. And then other ones I'll just, of the kidney disorders, but the diabetes insipidus you've already kind of know and have had some on, diabetes mellitus, and then the hepatitis. Because remember, urine doesn't always have to be related to a kidney problem. There can be other problems it detects. Okay, so this would be an example. It's still kind of hard to tell, but this is actually loaded with mucus, which would be a mini, or if you were a lab that did 4+. And we know the squamous are the largest. If it's eccentric nucleus, it's the renal. If it's a high NC ratio, it's a renal. If it's a center nucleus, it's the transitional. This is magnified way, way big, but these should be white cells, but it looks like it's even more than 100 magnification, so we know that's not. And this actually, little stuff in the background would possibly be bacteria. And this is more under phase, not a bright field. And then your transitional, this actually isn't really a good picture, so I would not. That looks more renal because it's a high NC ratio. I was trying to show, like this one is like a good caudate one, but the bulk of these are renal because it's a high NC ratio. But this, it's a little cockeyed, but it's more a center nucleus, and these are some good center nuclei. So if it has a lot of cytoplasm, then pay attention to where the nucleus is placed. And the eccentric or the high NC ratio. This is an oval fat body. And this is what I mean by the Maltese crosses. They kind of look like clusters of 4 that fluoresce, and it's under what is called a polarizer. A lot of labs can add an adaptation to their scopes that makes things polarized. It just looks like blobs. That's what I remember. I said like a lava lamp. I think it's a cell you look at and you think, now that doesn't look like, it's the size of a renal or an epi, like a transitional, but it doesn't look right. So that's you as a tech have to say, hey, I think, maybe investigate, see what their chemistry results are. Then we would have to ask our pathologist, hey, could you stain this urine? Could you use your oil red stain? And they would then, this is just using a polarizer light with no stain. If they use the stain, it helps you because it turns it red if it's fat. And then the cast, this is actually a big fat one with rounded ends, hyaline. This is just some junk that's on top, but it's not part of it. And this is a good hyaline cast. This is little strands of mucus. This is hard to tell if this is bacteria or not, but there is a little bit of mucus to the top side of it. But those are examples of hyaline cast. They're kind of soft and spongy. They're made up of TAM horseball protein that's in the tubules. And usually your red cell casts take on the brownish red color. Normally here we have to focus through, you like to see presence of red cells. So you tell me, based on what you know, how many white cells are in this picture and how many red cells?
0.
White cells, how many do you think?
1.
This is the only white cell. All of these are red cells. They're kind of dimpled in the middle, they're not granular. This has some junk on the outside, that's a red cell. That is the only granular one that's a size of a white cell. All of these are red cells. So a lot of times they break down into hemoglobin, so you don't see red cells in the cast. It's more a reddish color, it's the hemoglobin. But before I call it out on at your clinical, before you call a cellular cast, you better see those other cells free. Back it up. Because if a doctor comes and says, I want to see those renal epithelial cell casts you called, you better have free-floating renal epis in the field with it. Same way with the white cell cast, same way with blood. There better be blood on the dipstick at least if you're going to call a red cell cast. Because it could be hemoglobin cast because they've all broken down and you don't have free red cells. Make sure you call what is present. I'm not turning out any positive nitrite if I don't have at least moderate bacteria under the scope. I'm going to re-dip it and do it by hand to make sure my nitrite wasn't contaminated on my machine. You should be loaded with bacteria if you're calling nitrite on the dipstick. White cells, this, I don't know, must have been a stain one, but these aren't in focus, but these are actual 5 white cells. And you notice they have multiple lobes. Would your renal have multiple lobes if it was a renal epicast? No. It's going to have a single nucleus. This one is harder to tell because we're thinking these are white cell casts. So if I ever got a cast, I couldn't decide if it was, I knew it was a cellular cast. I didn't have blood on my dipstick, so I knew it wasn't a blood cast. I'm going to say cellular cast present, unable to determine type. You want to tell them there was a cellular cast there, but you're not going to tell them a type if you didn't see renals and you didn't see free white cells, or at least have white cells positive on your dipstick. And what is it becoming? You see how it's all granulated up here? Remember, a cellular cast becomes a granular cast the more it's in your tubules. The renal epi, once again, these are the hardest. Like this has a single nucleus that looks pretty high NC ratio. There's not a ton of cytoplasm. So we typically think that's a renal epi and not a white cell. And it's bigger than a white cell that's trapped. What do you think these are?
White cells.
I bet they're calcium oxalates if we can focus through it. And this one's hard to tell if it's junk Sulfonamides kind of take that shape if you're on a sulfa drug. It's hard to tell if, and this is some mucus in here. So, and that might, almost looks like a sperm. Might almost be 2 sperm. And this is hard to tell. This one looks more like a single central nucleus, why we might think it's a renal epithelial cell cast. So remember, that's your thing. Don't call a cellular cast without seeing the free cells. Just use that as a rule of thumb. This is what it looks like using the oil red. If it's not a fatty cast, it's not going to stain red. Okay, so that, you gotta know that. Maltese crosses with polarized light if you're not staining it. Otherwise, you use an oil red stain, and if it's a true fatty cast or an oval fat body, it will take the red color of the stain. If it's just a regular cast, it won't do that. Nephrotic syndrome has oval fat bodies, it has fatty cast. If you just use polarized light, you're gonna see these Maltese crosses. It's almost like a little group of 4 dots, especially if it's unstained. So those are both signifying nephrotic syndrome. Granular cast, this is probably a little coarser. If your lab where you go wants you to tell them if it's coarse or fine, if it's bigger clumps, probably of the 3, this is the one with the finer granules. This is more clumpy. But do you see, you can't really tell a cell, but it's come from a cellular cast. This looks like it was a white cell, possibly. This one I can't tell if it's just a big blob of junk, but this would be something, if I saw a lot of this look, I'd probably be thinking oval fat body and I better get that stained just to see. Or if we had a polarizer we could add to our scope. I'm not sure what all you'll get capable. Some places let you do phase and bright field on one scope, and then some of them have a polarizer they can add to a scope. So I'm not sure. Each of you will vary where you're at. Waxy and broad. They get very large, very rectangular. The waxy tend to have the little notches start developing. This one's not as wide, but it's very long. It's at least rectangular on the one end. It has a few little notches. Remember, that's end stage when you're not voiding. And then your red cells, this might be one granular white cell, but this is magnified greatly. It's hard to tell this one, and this one, but they look granular. Like if I focus through them, they're still going to look granular, but these all look see-through.
They're as large as the white cells, though.
I'm sorry, but this really is magnified more than you'd ever magnify a urine. This might be even 400 times. This is a good slide to distinguish squamous versus white cells versus red versus bacteria. So how many white cells?
3.
3. How many red cells?
4.
And you see this is rod-like shaped. Now Tiana and someone else had some rod-like stuff that had nothing flagged nitrite. So we knew it wasn't a bacteria because if you have that many gram negatives, they're rods. And they should have flagged it with that many that were shown, so we knew it was junk maybe from the tube, because those aren't sterile tubes. But I like this slide when you can see the differences in sizes. See how big the squamous is in comparison to the whites, in comparison to the red, in comparison to the bacteria. This is probably a good representation of a 40. Okay, that slide. This one, tell me, are there any white cells on that field? None. What are these?
Crenated.
Crenated. Those are all red cells, no whites. So in one field, and this one still looks like it is like a central pallor. So that is all red cells, no whites. So the reds are tricky. If they're crenated, you got to recognize that's on the outside. Focus through it. It's not granular where it stays within. And same one, because that one is a good one. This one is magnified probably 100 to 400 times. So these are much bigger than they would be, but I don't have anything different to help you. I wouldn't put this on a test because I don't give you anything to compare size. This is a great one to put on a test because you can compare sizes to have that help you. Sizes should help. Yes?
It's not a red or white, I can tell that, but in between 2 and 3 o'clock, little splotches, there's just like air pockets to your
This,
left.
you
Right
mean?
where your head is, honestly.
Oh, over here.
Yep, up, right
This,
there. Yep.
without knowing, it could be junk or it could be
Okay.
bacteria, but it doesn't really look like cocci. Like I think this might be bacteria, this might be junk.
Okay.
This, depending on if it was moving and looked like a rod-like bacteria, a lot of times bacteria don't take up stain too. And if you turn your light just right, you can get them kind of glow back at you, the bacteria. That's why I want you to play around with your light and your fine focus. Sometimes you get clues by using your scope right. And like Patricia said, just knowing that knob as you turn it on helped her with her light. That might have helped Anine. So
It really would have.
the Nikons are pretty nice. They have on the side, they have the diaphragm and then they have the condenser lever. You have to use your scopes correctly. So you've got to play around with the fine focus and the light to fit your eyes, okay? Because we all have a little bit different acuity with our eyes. And then the bacteria, this is magnified 100, 400 times. This is pretty good. This is what I mean. If you can, this is magnified more than 40 because the white cells are pretty big. But if you play with your light, you can many times get them to like glow back at you, the bacteria. So try every time we do urines that has, nitrites positive or potentially high white cells, try to play with your light. Yeast, I was kind of surprised we didn't see any yeast yet. Because a lot of times when we get specimens from the hospital, we almost always see a yeast. The problem is, if you see them singly, this is hyphae, which you'll learn yeast many times can have a mold phase, what they look like at room temp, and a yeast phase, what they look like at 37 degrees. This is more what they look like at 37. This is more what they look like at their mold phase. And they call it mycelial elements. All you have to do is say yeast is present if you see anything like this. And they can mimic a small red cell if you can't tell they're budding. If you just saw this little thing, you see they're see-through. They're not granular through. So you got to make sure. We always kept a little bottle of acetic acid by our scope. And if I had a ton of what I was either going to call reds, but how would you know that they may not be reds? What would be different on your dipstick? There wouldn't be blood. So then you might think they might be yeast. I have all this stuff on my slide and I don't have any blood flagged on my chemical. I better make sure if it's yeast. So if I add the acid, if it's blood, it's going to go away. If it's yeast, it stays. So we would sometimes just keep a little bottle of acid and add a drop before we called it. And then trichomonas, this is what I was hoping to see over there, but there was nothing modal. They just all look like white cells. But usually when they're modal, you can see they have a little tuft of little flagella on one side. And you'll see it going back and forth like this or scooting across the slide. And I knew if she put them in the refrigerator we wouldn't have anything, but it didn't help keep them in room temp either. Because I looked at both tubes. And I put it on a full big cover slip, not just the little one. So, and then sperm, it looked like that one slide previous had the sperm, so more on a bright field. Now this would be something you'd really want to focus through because those could be two little air bubbles, or if you get starch particles at all, you'll focus through them and it'll reflect back like light. It looks like little mirrors. And then your uric acid, and what is going to be your clue if it's a crystal is the pH. So when I put all the crystals on, I give you pH as the clue. since you know you're getting calcium oxalate, I'm not giving you the pH, because that's the only crystal I'm gonna give you next week. But uric acid is the one that has varied shapes, and it's acid pH. Calcium oxalates, these are magnified greatly, but I think you all feel okay about those. They kind of stand out. Even in 10, you can kind of know you have them, because you'll be focusing through, and they got these little glowy things that when you go to 40, then and they got bigger. Some of them had bigger ones. The longer they had sat in the urine, they were bigger size. When it's a fresh urine, they won't be that big. Amorphous sediment, I'm not going to make you know urates versus phosphates depending on the pH. We'll just call it amorphous sediment. That's what we did at St. Eve's. We saw any amorphous, and what was your clue on an acid pH one? Pink sediment when you spin them. That's a big clue. The alkaline crystals, the envelope ones are the ones you see the most commonly. When the triple phosphates get turned on their side, sometimes they look like coffin lids. But what's the pH? Greater than 7. And then I call the ammonium biurates, sometimes they call them the thorny apple. Those are pH of 8. I call them the little aliens. And then calcium carbonates are known to be the dumbbell-shaped ones. So a lot of times they'll show pictures and they're very small little dumbbells. Okay, so they look like a little set of dumbbells, and that is pH of 8. All of these are normal, nothing bad. Pathological ones, tyrosine and leucine go with liver disease. So what are you gonna also see before you go calling them as a tech? You better have some elevated what on the chemistry panel? Liver test. And you better see what? Bilirubin and possibly urobilinogen elevated on the dipstick. You're not going to be calling them if you don't have correlation with chemistry and with the dipstick, okay? Don't just randomly, because I think when you're new, you think everything's bad under the scope, and half of it is junk, and it's a fiber, an artifact. Leucine looks kind of like I said, for me, the cinnamon roll or a snail, or like someone said last year, the tree trunk, the striations of a tree trunk.
That's what I see.
You know, so whatever, those both go with liver. The needle-like ones of tyrosine and the leucine. And then the cysteine, we're going to talk about with the amino acidureas. There's cystinuria, and those people can have cysteine amino acid spilling out, and then they form a cysteine crystal, and they're hexagon shaped. So it has nothing to do with liver, it's an amino acid problem. Okay, and they're the hexagon shaped. And then the cholesterol ones kind of, to me, look like notched plates of glass. They're very flat, not three-dimensional, like they're laying on top of each other. Sometimes you could see them with your nephrotic syndrome, with anything with liver problems, with any lipid problem. So that's not common one though. Okay, so we're going to end there. It's already 1:30, so we're going to at least finish this PowerPoint on Monday. So we'll do amino acidureas for the next test, but you know for sure we'll finish the rest of this Monday before we do amino acids, and then amino acids will be on the following week. So we'll just go through, because we still got to do fat and clearance calculations. Let's do one of them, just let me show you. We won't talk about it, but I want, look in your syllabus for a thing called a nomogram. Let me practice one with you, because you only get to hear about it on Monday for the test on Tuesday. So let's practice one, and we'll see that. Look in your syllabus index at the beginning for a nomogram. You're going to need to use that. We're going to have a child that is 4 foot 8 inches, 85 pounds. So keep that in mind. they feel some kidney issues. The creatinine is 3.0. The urine creatinine is, I don't know what I want to say. I don't know what I want to make it. We'll just say 20. And the volume is 1,000 mils in 24 hours. So, the formula is U times V. P is plasma, S is serum. So P is the plasma creatinine. Volume has to be in mils per minute. Then a typical surface area is 1.73, and then we got to figure out the surface area of the patient. So you need to use the nomogram. What page is that? Now put mine on the Elmo.
54.
Tell me how you think you use that. You got the height and weight. And page 55, we're going to fill that out right now. So 55, we're going to fill it out right now, and you're going to turn it in to me. How do you think you use this? Anybody figure it out? You can use the straight edge of anything, a piece of paper. What is the height of the child? Let me turn this and we'll see if you can see it if I put it on the Elmo.
This will be 143.
So we need the height. I wonder if I should. We want weight versus height. Let me see if, I don't know if it'll show. I have a better copy in my folder back in. So we said it was 4.8 because it's a little blurry.
I think it's 142.
4.8. So here's 5 foot. Here's 4.8 right here. And it's 85 pounds. Weight in pounds is down here. So does everybody see my two dots? Let me make them bigger. So 4.8 and 85 pounds. Can everybody see that? Then you take your straight edge, and to me it's right below 1.15. Let's see, probably 1.14 maybe. You got to go dot to dot, and your surface area is in the middle. So we'll put it right here. This is the surface area when I go dot to dot, and we'll go with 1.15. I'll get you a better copy than the one in your book for Monday. So we know our surface area is 1.15 of this patient. So, what I like to do before I plug everything in, I like to get everything I need. So we got my surface area of the patient. This is a constant. This is the average surface area. That's why if it's a normal sized person, a lot of people don't do the surface area. They figure it'll be just one and balance itself out. We know the urine creatinine is 20. We know the plasma creatinine is 3. How are we going to figure out mils per minute? We know we had 1,000 mils in 24 hours. How do I get 24 hours in minutes?
Times by 60.
Times 60, right? So is that 1440? Anybody got anything out? You gotta get your volume in mils per minute because that's gonna be your GFR. So if we take 24 hours and there's 60 minutes in every hour, you have 1,440 mils per minute. What's the units of creatinine? Milligrams per deciliter, right? So they're gonna cancel, right? If this is 20 milligrams per deciliter and this is milligrams per deciliter, they cancel out. Your GFR or creatinine clearance is reported in mils per minute. Or that's your GFR, your glomerular filtration rate. So let's see what kind of value. I might have not given a good urine creatinine value. We'll see what it is. So I'm going to take 20 for the urine creatinine times 1440. That's mils per minute. Is that right? No, it isn't right. I had to divide. I already messed this up. Mils per minute's not going to be that high because I had to take in the volume. So how do I get the mils per minute? I take 1,000 divided by the 1440, right? Did everybody see that? There was 1,000 mils in 24 hours. So there was 1,000 mils in 1,440 minutes. Okay? So 1,000 divided by 1,440 equals 13.9. That doesn't make sense.
1,000 divided by 1440?
Right.
I got 0.69.
Right, so I had to do something wrong in my calculator. 0.69? So we'll do 0.7 mils per minute. Does everybody see how I got that? This was my mils I had to give you, and I gave you how many hours. If I had said it was a 2-hour collection, what would I have multiplied the 60 by? 2 times 60, right? It had been divided by 120 minutes. So I'm going to give you a problem for homework so that we'll practice it and we'll go over another one in class. So does everybody see? I took 1,000 mils. The 1,440 minutes came by taking 24 hours times 60. And then the 0.7 is when I divided them. Okay? So I like to get everything and then set my formula up. So I do this first. For me, this works the best. I do this first, then times it by 173 and divide it by 115. So we'll take 20 times 0.7 divided by 3, the plasma creatinine, and that, it was 4.7 about, and then I multiplied that by 1.73 divided by the surface area, 1.15. And I came out with 7. So there's an issue there, right? That child has pretty well gone into renal failure. They're less than 25 mils per minute. So I probably should have given a little bit higher creatinine on the urine. So let's do one for practice. Don't turn this in, just turn it, put what I'm going to ask you on the right next to it. So this time you're going to have a male. Going to be a 6'3" male, and they're 250 pounds. Okay, so you're going to have to figure out the surface area of that, and this time you're going to have 600 mils in 6 hours. So you've got to figure out the mils per minute. You're going to have a plasma or serum creatinine of 1.6, I think it's grams per deciliter. And the urine creatinine, we're gonna say 30 grams per deciliter. Okay, so you have everything you need to figure that out. So I want you to take that home and work on it for next Monday. So everybody should write 6'3", 250, that, and you gotta figure out the surface area using that nomogram. Your plasma creatinine is 1.6. The urine creatinine is 30 grams per deciliter. You've got to figure out the mils per minute from 600 mils, and it was only a 6-hour collection. It wasn't 24 hours. So the first thing you're going to do is take the 6 times 60, right? Equals 360 minutes. Then you're going to take the 600 divided by 360, and there you have your mils per minute. So you're going to have to do this on your test on Tuesday, and you're going to have to tell me if it was normal, increased, or decreased. Yes?
So you want us to do the first one on this?
I want you to have both of them on that.
Oh,
Yep. I don't care if you put it on another piece of paper, staple them together, and then we'll turn it in Monday.
So, yeah, like, we decided 107. The male is 107.
Right. Male has a higher normal. Okay, so bring that in for Monday. I'm going to have all your, the other homework you're going to have is the MTS. You got to have that test done that you have to do the microscopic with it. That'll help you. It goes into how you grade. It's a great, great tool for the microscopic is the MTS, and then you'll have it done for your portfolio and done for your analysis. And then what else? So your test will be over this PowerPoint and microscopic, and you'll have 10 slides. You'll have 12 slides, and it'll be the best 10 out of 12. Okay? And then we'll do amino acidureas and intro to body fluid and spinal fluid probably for the next test. Oh, for the...
okay, I was still over there.
Oh, okay. And then the other thing, remember,
I haven't gotten
well, I'll put it on the review. When I give you the review sheet, I'll tell you which one can potentially be case studies. Okay? So that way you'll know what results to key into. In our world, as your common everyday tech, you may see an acute glomerulonephritis. I know you'll see a pyelonephritis. I know you'll see a cystitis. Will you see nephrotic syndrome? I'm not sure, but I can almost guarantee you're going to see that on the registry. Will you ever see a tubular? I've had many urine for eosinophils. I don't think I've ever had a positive one where I knew it was interstitial nephritis. I've never personally called a renal tubular epithelial cast. So we know you'll see hepatitis. We know you'll see diabetes insipidus and mellitus. So we need you to really recognize the everyday common things we know you're going to see. The others, you're going to have a pathologist involved.